Okay, a lot has been covered in the previous three talks. So we'll just probably go through on the case-based pattern and see what we can, how can we select what all has been discussed. So this is a patient and a 71-year-old gentleman and diagnosed with renal tumor in 2001, underwent a left nephrectomy. And currently, he presented to me in the clinic, this was in 2018 when he presented the history of some sternal bulge and no pain. And they were actually, they thought they went to a party and somebody pointed out, you have a sternal bulge, and then they came for an opinion. It's been there for some time. So more of a cosmetic reason rather than anything else. And they got it biopsied also, and it was a clear cell grade 2. And mediastinal nodes approximately 2 centimeter, with this being there for the past 6 months. Previous 6 months imaging was available with them. And of course, we had the workup of the IMDC and turned out to be favorable. Only thing was the anxiety. The family was anxious. They started taking opinions after that party, and so they were anxious. So what is the options that you have? Now you have data of Pembro-Axi over there that was being discussed, and somebody said that you can actually induce a CR. So I think so. Dr. Amit said that, yeah. So Dr. Amit, would you want to go for a CR, observations, sunitinib, or any other?
So it's a 71-year gentleman, asymptomatic. I think so. Observation is also a good
you
option.
Presented our observation data also. I think so. By Rini et al.
Yeah.
And that was important data. I think so, because of it being an immunological nature of disease, this could be I think so. The rest of the panelists, would anybody differs on that? Yeah.
So I would like to add one point. If we see he's asymptomatic, the sites of disease are one sternum, that is proven.
Yeah.
Mediastinal node, we don't know. So in this scenario, possibly locally ablative. If
mediastinal was the uptake was there, and then it was 2 centimeter node. So yeah.
So according to me, the sternal lesions generally they increase and cause pain. Rather, it would be prudent to put him on some at least TKI rather than only wait and watch. That would be my
okay. Opinion. So one is for observation, and Dr. Santosh is for TKI. Yeah, please. Doctor.
So by the book, definitely pembrolizumab axitinib with all the data, but observation is also an option. We have done that in the past, even before this. So that local therapy can also be planned, like local radiation to the sternum or there's something, because it's a single site disease. If the mediastinal nodes are not proven, and if we think that it was there from last 6 months and same, there's nothing. Local therapy, why not? This can be a curative option.
Okay, so the house is divided over here. And then we have Dr. Joshi is there. So Dr. Joshi, your point of view.
I mean, it's anybody's call. To be
anybody's call. True. I think so. It would be a divided house. This patient has been moving actually all over NCR getting opinions, and it was, wanting to hear observation would be one of the most favorable things.
So I think here we should look at also the toxicity. Even if it's a TKI, for all said and done, sunitinib will induce some amount of toxicity and quality of life issues. A seemingly low risk disease, a very, very sort of oligometastatic, I think I would observe. I would give an option of observation for sure.
An option of observation. I guess, I mean, in this era, we all are practicing and we are giving options for sure. So it's not just one thing. An option is always there on the table. True. So I think so. Pembro-Axi is showing some, data over there, and does become an option and observation as we all discussed. And this observation data basically, it comes from this particular, it gets more evidence. Earlier it was there, but it gets more evidence in this particular trial by Rini et al. And I won't go into the details, but then they saw that, the overall survival was actually, once you start the treatment on progression, you can actually give a good overall survival there as well. So eventually this patient progresses, and this is now a hypothetical scenario. That patient is still continuing on observation. So this patient progresses and CT scan is done after 6 months. Patient remains asymptomatic. So IMDC is favorable still. You do not have any change in the hemogram calcium levels. What is the option now? It's a slow biology disease, as we have all gained that insight. So yeah, Dr. Preeti, would you want to take that? Or
So it will also depend where the progression is, whether the patient has progressed locally or whether the patient has progressed systemically also. So where the progression is, if the patient is asymptomatic and there is small size is increased on observation, then I would like to observe only.
So now I split it. Actually, let's say there is oligoprogression, but then it is, small subpleural nodules coming up. So since I made this hypothetical scenario, so I did not put up pictures over there. So subpleural nodules coming up over there. And still the patient's profile is
symptomatic, but subpleural nodules are coming up. So then I would like to add on some therapy. I would like to go for TKI and IO.
TKI and IO. Your call, doctor.
So if it's only subpleural nodules and that has happened in 6 months, and I mean, if they're not really bothering, when we have observed him for 6 months, why not continue until he's actually, landing in a full-blown disease or his symptomatic? I mean, when we are already doing that, I think this particular scenario, I would want to observe for some more time.
You want to observe for some more time? So we are getting a split house again, okay? So Dr. Santosh?
So I think as far as I remember in the RINI trial, progression after 6 to 8 months, I think they have started
the treatment. If in case
here
in the trial, they start the treatment once the patient starts progressing.
So going by the data, yes, we have to start the treatment right now. So to choose an agent in 71 years, maybe cardiovascular status also be taken.
Okay, let me put it this way. Leave the cardiovascular status away. So I think so. I wanted to highlight the debate between the TKI, IO and the sunitinib. So is sunitinib still there in the race? Leave apart the financials. So is sunitinib still there in the race?
Surely, sunitinib is there in the race, I would say. So if it's in the favorable risk, elderly patient with the minimum toxicity, I think sunitinib we can plan in this patient.
Would be there in the race? I mean, you believe that in the favorable risk category, or as the doctor said that she would add TKI and IO?
Might be I'll reserve the IO for the next sunitinib upfront.
Okay, I think so. With the favorable subset, if we look at this, I think so. We are getting the responses in TKI and IO. The curve and the balances are shifting in the terms of PFS for now. That's for sure, and that's why we think that is sunitinib still there or is just out of the picture. So, but then it seems that the overall survival impact is still, one of the major things that we all look forward to. But for that matter, I think so the guidelines are changing their gears towards putting sunitinib as an alternative, even in the good risk category. So it is now probably from a recommended thing has come as an alternative, and that's probably because of the PFS benefit being seen and an expectation that it would also convert into an overall survival. So though it is not giving up easily, and the IO combination definitely is lagging behind if in case you have a favorable risk scenario, and it's not the way to go about, definitely. I just wanted to highlight that there are certain in the favorable subset, the angiogenesis biomarkers basically on the T stroma, which is there, which is expressed. So I think so. For now, we do offer. I think so. If I may conclude that we do offer sunitinib, if the difference of opinion is there in the house also. So we do offer sunitinib as a alternative. And okay, switching towards the next profile of patients, and that's a 45-year-old patient presenting with a history of diabetes and a recently diagnosed stage 4 RCC, clear cell with a sarcomatoid histology as a focal histology, type 1 diabetes controlled pretty okay. But he's having lymph node as a metastatic site lung. His hemoglobin is 8, so IMDC appears to be poor. He's having hectic fever. So it's a IMDC poor and sarcomatoid histology. So to all panelists, we do not have a surgeon over here, so this question will not stay for long. So surgery, any takers over here? at some point of time, not upfront, Carmina is being already projected on the board. So, but at some point of time, certain strategy.
Yeah, sure.
Once you give probably a chance.
Yeah, after 6 to 9 months, if there is a very good response and there's a very limited disease, surgery is still in the picture.
I think so. That even the IO trials, if the house agrees, even the IO trials have shown that once you get a good response going, probably cytoreductive surgery is adding on to benefit. So, okay, so which regimen over here is the next question? IO TKI. The disease is moderate. It's not bulky. It's hectic fever, sarcomatoid histology. If I'm giving any clues over there, so IO TKI, and IO TKI cosmic 313 as doctor presented.
So the sarcomatoid variant that in histology, it portends poor prognosis. That is the first thing. And I would use a combination of IO TKI with cabozantinib, possibly nivolumab plus cabozantinib, that works better in sarcomatoid compared with other histologies.
Okay, so Dr.
So right now, I don't remember the percentage of the sarcomatoid representation in different trials, but yeah, so per risk IO I would prefer, and when we want faster responses, we go for IO TKI combination. So barring the sarcomatoid histology, I think IO for this one.
So if in case you are offering the TKIs, Dr. Santosh mentioned clearly that cabozantinib is his favorite, but I have had I lost one patient, I must admit that. It was actually, that's a black box warning also mentioned over there, and that's GI perforation. So the patient went away out of India taking that tablet, and eventually had some abdominal pain, got a X-ray, air under diaphragm. So eventually, cabozantinib has its own issues, so which must be taken with a pinch of salt. So I probably became more apprehensive about cabozantinib, but hearing you again, so I am gaining some confidence. But any one of your favorites over here?
Axitinib, because of the shorter half-life and probably more experience with it. And lenvatinib I've used, and I think I'm comfortable with it.
Doctor, your favorite over here. So Dr. Santosh has clearly mentioned cabozantinib-based therapy is his way to go.
I also prefer axitinib. Axitinib is a safer to use, shorter half-life. Lenvatinib, the dose is 20 milligram OD. It is difficult to more mucositis, more hand-foot syndrome, more fatigue. So my preference is axitinib.
Yeah, Dr.
Might be it's a toxicity management. I prefer lenvatinib with pembrolizumab.
So I think so. Some of you rightly pointed out that we have been using, probably because of the first mover thing, axitinib and pembro came, and more data, getting more familiar with it. But yes, I think so. What Dr. Santosh said and Dr. Amit said that these drugs are coming up, and the exciting data about more CRs being there. So that definitely, and the bone metastasis where they actually add. We do think about this when these subsets actually fall, so definitely it becomes important to, these ideas do flash up. But I think so eventually the no cross trial comparison, it's not really easy. My take is that it's better where you can actually follow up the toxicities, and you're used to what somebody said, that you can manage those toxicities, short half-life, you can follow it well. So that could be one favorite choice. So of course, there is some data, and it's sort of cross-trial comparison. Again, pembro axi, what we think that the CRs are not so quite prominent, but it's actually not so bad as compared to nivo and cabozantinib. It's again not a fair way to look at things, but there is a good overlap of the PFS and the overall survival curves. So talking about just the cross trial, this table we have seen again, and we keep on seeing, this we tend to sort of do this comparisons. So of course, here CR is one thing, definitely more CRs over here, but here again CR, but then the dose is a bit of problem. And as you rightly pointed out, that you need to sustain that dose, and probably then you would be able to look at this sort of CR. So that's a bit of challenge over there. And I think so the panel rightly pointed out this particular thing that, with the burden of disease, that there is always an apprehension that the disease would progress if in case you start with a combination IO combination. So definitely a moderate burden of disease could be the way to go ahead. And that would be a good choice in intermediate and poor risk category. So definitely we heard this particular thing that it's a good choice. Long-term survivors in intermediate and poor risk category, and 48 months is what we saw in this particular subset of patients. With the total intention to treat population was going actually much beyond not reached yet, the overall survival. Sarcomatoid histology, again, this slide flashes in front of our eyes when we see sarcomatoid histology. Do you agree, or this data is pretty well there in this particular trial? The subset analysis has been shown and projected. So this slide does flash in front of our eyes. But the apprehension to use is always the dose of the ipilimumab and the toxicities. So what is the dose that you adopt, Dr. Amit, because you... So
basically I haven't used, but surely it's a 3-weekly dose, which is more commonly used.
Okay, and the PRISM strategy, if in case you want to comment on that. And this was the PRISM trial where they actually gave nivo-AP was the modified into, AP being given every 3 monthly with intervening nivolumab being continued.
So ipilimumab being the most worrisome drug for its colitis and all, preferably I would go, instead of 3 mg per kg, 1 mg per kg is the way to go. Previously they used 3 mg and 10 mg. The answer is clear, 1 mg per kg, 3 weekly possibility, that is the way to move ahead from it.
Yeah. Your experience with ipilimumab, and because my experiences with AP is also very, small, and therefore I would want to know, and also from the house, Dr. Mohit is there, Dr. JB Sharma sir is there. So, after the panel completes, we can probably have comments on AP from the house as well.
I take no pride in admitting I had one patient and I had given nivo AP and we lost the patient after that, after one cycle. So that was the only time I gave nivo AP. And
so we are running nivo AP trial around 25 patients up until now. I think toxicity is not been the concern. We are using the initial conventional regimen of 1 mg per kg with 4 cycles, and then going back to on that.
Okay.
Except for one patient who had a bad hepatitis, I think that patient needed a withdrawal. But I think up until now, toxicity has not been a concern.
Toxicity has not been a concern. JB Sharma sir. Mohit.
Patients are already taking the body very aggressive and using the entire issue process. But body was there, and it plays a lot of body.
Okay, I think so that there is some apprehension, but Dr. Joshi has infused that confidence back again. Probably you can go back and try it. So this is one strategy there which is available, and you have data now to say that the toxicities would be lesser if in case you are using this way, modified AP, because you look at the diarrhea grade 3, grade 4, and it has come down, with the modified strategy, and you look at colitis, so that those numbers are also down. So overall, basically the discontinuations are lesser as compared to the standard strategy. So 22% versus 39%. And so post-progression, shifting gears towards that, and what are the second line options? I'm not talking about, yes, we agree what Dr. Amit mentioned, Dr. Santosh mentioned that, ablation is always there, local therapies are always there, but talking about medical therapy. So post-progression, if the patient has progressed, how do you choose, how do you go about it? TKI or IOTI TKI combination?
So it depends on what patient has received in first line. So if patient has received IO in first line, so no IO in second line. The patient has not received IO in first line, then of course IO in second line.
So there was this bit of discussion that add epi later if in case, Pembro and Axi was given, Nivo epi probably as. Would you agree with that particular concept? There was a comment by the chairperson also that it would not act well.
Yes.
So after Pembro, it is not, but after Nivo EP, there is a trial of Pembro plus lenvatinib, and in that trial they have shown a decent response to Pembro lenvatinib after IO. But after Pembro with Nivo, that is failed.
Yeah, I think so. This particular analysis of all this Titan and Omnivore, these are trials where IO has been introduced again. The chances that you get a response with a IO combination is not the way to add CTLA4, reserve it for later. If you want to use CTLA4 inhibitor at some point of time, consider it using early. So I would conclude that IMDC favorable risk observation is an option. Of course, you keep it as an option with the discussion of treatment. And sunitinib is still in the race till we have more data maturing. It still comes in the discussion as an alternative, though in the clinical guidelines. So if for IO, if you want to have durable responses, CRs matter. So without many side effect of TKI, and that what I think so. Dr. Kripa showed the analysis of quality of life. That's so important. Probably IO for some reason is having the better quality of life. Again, a cross-trial situation over there, but this is what we can do for now. So certain histologies, sarcomatoid histology and brain metastasis, there is clear data of IO. And IO TKI for a quick and durable response, but quality of life issues are there which need to be addressed. And I think so we are concluding that if in case you want to use this particular drug, IPI, then you better use it in the first line setting in a selected subgroup of patient rather than keeping it for a later line. Thank you.